Welcome to today's Login to Learn titled The Power and Promise of Treatment as Prevention and the U equals You campaign. I'm Marita Merman. I'm director of the Region 2 Public Health Training Center. We're one of 10 regional public health training centers funded by the Health Resources and Services Administration. We are a collaboration of Columbia University, Mailman School of Public Health, Rutgers School of Public Health, Impactivo, a consulting firm located in San Juan, Puerto Rico, the New York State Association of County Health Officials, and the St. Croix Foundation located in the U.S. Virgin Islands. Our mission is to enhance the public health workforce's ability to effectively deliver the essential public health services to the populations in New York, New Jersey, Puerto Rico, and the U.S. Virgin Islands. Our nationally designated public health content area is health disparities, health equity, and the social determinants of health. It now gives me great pleasure to introduce today's speaker, Dr. Perry Halkitis. Dr. Halkitis is the Dean of the School of Public Health at Rutgers University, as well as a professor in their departments of biostatistics and social and behavioral health sciences. Dr. Halkitis' research examines the intersection between the HIV epidemic, drug abuse, and mental health burden. His research center, known as the Center for Health, Identity, Behavior, and Prevention Studies, serves as a training site for the next generation of scholars and partners with community agencies to conduct studies for and with the LGBT population. Throughout his career, Dr. Halkitis has been on the forefront fighting for the rights of those infected with and affected by HIV, as well as being an outspoken advocate for the health of the LGBT population. Dean Halkitis.
Thank you, Marita, and thanks to Login to Learn and to my colleague Mitch Rosen for this invitation to present to you here today. It's amazing to me, some 37 years after the initial diagnosis of HIV in the United States, how much progress has been made. While there is no doubt that work still needs to be done, the advances in treatment and in care and in prevention have altered the direction of the epidemic since 1996. And so today, I'm here to talk to you a little bit about one of those amazing advances that has shifted the epidemic. We will be talking about treatment as prevention, and particularly about the U equals You campaign. The learning objectives for our session today are to describe the challenges in working with clients to understand the tenets of U equals You, to describe how U equals You can be combined with other biomedical technologies to help curtail HIV infection, to describe how biomedical technologies function to counter the stigma associated with HIV, to list the barriers associated with the uptake of HIV biomedical technologies, to describe how U equals You can be leveraged to counter outdated HIV laws and policies, and finally, to describe the role patients have in advancing the U equals You message with their providers. What you see in front of you is a release from the Centers for Disease Control and Prevention that was published in 1996. 1996 was a turning point in the epidemic because of the implementation of a new class of medications called protease inhibitors, but also because of the development of combination therapy, what became known as highly active antiretroviral therapy that we now refer to as ART. At that point, there was a rapid decline in the death of people living with HIV. I remember that time very clearly. I remember people who were extremely sick becoming suddenly better. And because of these advances, people who are living with HIV have the possibility nowadays, if detected early, if on treatment and in care, to live a normal life expectancy. This chart, this in front of you, shows AIDS classifications and people diagnosed with HIV infection in the United States between 1985 and 2015. And what you can see is the sharp decline between 1996 and 1997. A shift, a huge shift in the epidemic in our country. Before I speak about treatment as prevention, I want to talk more broadly about the context of biomedical advances. This includes pre-exposure prophylaxis and post-exposure prophylaxis, known also as PrEP and PEP. Pre-exposure prophylaxis is an HIV prevention method that was approved in 2012 by the FDA. Pre-exposure prophylaxis is the use of one antiviral, the currently only approved one is Truvada, to prevent someone from acquiring HIV who is HIV negative. If taken effectively, if dosed properly, PrEP is an extremely effective method for preventing HIV transmission. There is strong evidence for PrEP as part of numerous trials, including the IPREX trial, the Partners trial among serodiscordant heterosexual couples, the Bangkok tenofovir trial, all of which showed PrEP was powerful. However, there is also some weak evidence from the FemPrep trial and the TDF2 trial. And these weaker findings are often associated with the challenge we have with medication and adherence, no matter what disease we're talking about, which is taking a pill every single day. Fortunately, nowadays, there is developments of injectable forms of PrEP that hopefully will require less than everyday dosing and hopefully will help to undermine the challenges created by adherence. Right here in front of you, you see a chart that shows the percentage of individuals who have taken up PrEP as a prevention method. It is estimated that about 1.1 million individuals in the United States would benefit from the use of PrEP. However, some 10% are on it. And what you see in front of you is also the great disparity that exists across race and ethnicity. While Blacks and Latinos, Latinas, Latinx are most affected by HIV in our country, and are most at risk for acquiring HIV, they are also much less likely to uptake PrEP than the white population. So we have work to do. I've been doing a study since 2009 called the P18 Cohort Study. This is a study that's been funded by National Institute on Drug Abuse to examine risks and resilience in men who have sex with men. The cohort was 18 years old at the onset of the study and are now about approximately 25 to 26 years old. I am showing you some data here from phase 2 of our study, which began about 5 years ago, that indicates awareness and use of PrEP. What you can see is in this young population, this early 20-something population of mostly racial ethnic minority MSM, is that almost all of them are aware of PrEP. However, only 14% have ever taken PrEP. Fortunately, as I said, there is the next generation of PrEP, long-acting injectables, which are being tested perhaps every 2 months, tenofovir in combination with other medications that can lead to less renal toxicity, and VRC01. In addition to PrEP, we have post-exposure prophylaxis, sort of like the cousin of PrEP. Post-exposure prophylaxis is an indication that when ARVs are taken after somebody is exposed to HIV, they can prevent the proliferation of the virus in the body. PEP has been used since 1988 as a way for preventing infection in healthcare workers due to needle sticks and other possible exposures. Nowadays, PEP is described both for individuals in the medical field OPEP, occupational PEP, and non-occupational PEP, or NPEP. There has been no randomized controlled trials of PEP, which I think should be obvious why, because we cannot randomize people to acquiring HIV. Still, there is strong evidence that PEP is effective. The challenges with PEP, of course, is that you must act fast. You have to have been exposed within 72 hours. Unfortunately, most individuals do not realize they've been exposed within 72 hours, rendering PEP not particularly helpful. PEP for non-occupational exposure is not recommended for those who are HIV positive, and it's not recommended for those who have been exposed more than 72 hours after exposure. OPEP and NPEP both consist of a 28-day course of regimen of 3 antivirals, and there are preferred regimens that the CDC recommends. Okay, so why do I bring up those two? I raise PEP and PrEP because I think it is incredibly important as we think about biomedical technologies in the United States to think about the entire landscape. Treatment as prevention and U equals U functions alongside PEP and PrEP and the use of condoms and other barriers as a means of preventing HIV. So now let's talk about treatment as prevention. Treatment as prevention is the idea that individuals who are living with HIV, who are adhering to their medications, and who have negligible levels of virus in their body are unable to transmit virus to their partners. There have been a series of studies that have examined treatment as prevention. Treatment as prevention frames the provision of HIV treatment as both an individual and a public good. It is an individual good because the individual is taking care of their health. It is a public good because if the individual is virally suppressed, the individual then has, as my friend Bruce Rickman would say, the developer of the U equals U campaign, zero chance of transmitting HIV to their partners. There have been models, mathematical models, with regard to HIV testing and immediate ART prescription to eliminate HIV transmission. The model suggests only universal HIV testing and immediate ART could reduce transmission to eliminate HIV by 2020. In New York State, Governor Cuomo called for an end of AIDS by 2020. What he meant was getting infections down from some 4,000 to some 750. One of the ways of doing that is by identifying people who are HIV positive and putting them on treatment. But this requires that we test everybody and that we are vigilant in putting people on medications. But as we all know, those of us who are doing HIV work, individuals live for very long times without being treated for their HIV, and as a result are transmitting virus to their partners. This mathematical model shows also what would happen if we treated treatment as prevention and we had universal HIV testing and immediate ART. The incidence of HIV per year would be greatly reduced. There's a study that was conducted in Vancouver that indicated that increase in ART coverage reduces the population viral load and new diagnoses. This study indicated through modeling that there was a significant association between increased ART coverage, reduced community viral load, and decreased number of new HIV diagnoses. What does that really mean? What that means is that if we identify people who are HIV positive, we put them on treatment, the amount of virus that is circulating in the population, in the community, greatly reduces. And as a result of that, the transmission of HIV to HIV negative individuals is much less likely to occur. This chart here is another way of looking at it, showing us mathematically what would happen if we were to implement treatment as prevention widely. Community viral load, a term I used a couple of moments ago, is a concept that refers to the aggregate individual viral loads of people in a specific population or in a specific community. And it was developed as a metric to quantify the level of virus that's circulating in a particular population. The logic behind this idea is that when you identify infected people, when you attack the virus by reducing viremia in the person through the implementation of ART, the individual's viral load goes down. But if you do this collectively across a population or a community, the community viral load goes down. This has been demonstrated beautifully in the study that was undertaken in San Francisco that showed that reductions in community viral load were associated with sharp decreases in HIV infections and suggests that large-scale ART could reduce HIV transmission at the population level. What am I saying to you? I'm saying to you that we have no cure for HIV. Right now, the best tools we have are these medications. These medications used to treat those who are infected, these medications used as PEP and as PrEP to prevent infections for individuals who are susceptible to acquiring HIV. New York City has been a rather remarkable place, a rather remarkable lab in terms of HIV and as a model for the country. And what you are able to see in this somewhat complicated graph is a steady decrease in new HIV infections since these biomedical technologies have been implemented and since the New York City Department of Health and Mental Hygiene has been a strong proponent of both treatment as prevention and U equals U, pre-exposure prophylaxis and post-exposure prophylaxis. So what evidence do we have that treatment as prevention actually works? Well, the HPTN 052 study was a phase 3 two-arm randomized control trial, multi-center, to determine whether ART can prevent transmission of HIV in serodiscordant, i.e. one positive, one negative, couples. It enrolled approximately 2,000 serodiscordant couples at 13 sites in 9 countries. The majority of the couples were heterosexual, and the couples were randomized either to early ART, which is that the individual who was positive went on medications when their CD4 count was between 350 and 550, or delayed ART, the individual who was HIV positive went on medications when their CD4 count was less than 250. And what was amazing in this study was that 8 linked partner infections were diagnosed after the index partner started ART. That means that there were only 8 cases of transmission in this huge sample of some 2,000 couples that happened, these 2,000 couples who were having sex, that occurred after the HIV positive person was on treatment. Now, what's interesting is that in looking back and disentangling the data, one could say, well, this is some evidence that treatment as prevention isn't really completely effective. But in fact, what the scientists and the researchers were able to show was, in fact, that these infections occurred right after an individual had started ART treatment. So perhaps that person's viral load was not completely suppressed. Treatment as prevention from the HPTN 052 study indicated that if individuals start ART early, we can reduce HIV transmission by 93%. And there is a zero index to partner-linked transmissions when the index participant was stably suppressed to ART. What does that mean? When an individual is when an individual in this study was found to be HIV positive and had undetectable viral load, based on the most advanced technologies we have now to detect viral load, there were 0 infections to the partner. That is a huge, huge finding. The partner study was another source of evidence about treatment as prevention. This was not a randomized control trial, but rather a prospective observational study conducted at 75 clinical sites in 14 European cities. It enrolled approximately 1,200 serodiscordant couples who reported condomless sex. Eligibility criteria were condomless sex and an HIV viral load of less than 200 copies. And the scientists, the researchers, used phylogenetic analysis if an HIV-negative partner became infected to determine phylogenetically linked transmissions. And for those who may not be aware, phylogenetic analysis is a technique that we've been using over the course of the last several years to link infections to clusters. So for example, if somebody tests positive in New Jersey and we do a phylogenetic analysis on that person's HIV, we may find a cluster of infections in a particular location that indicate that that person was probably infected by an individual in that particular location. Why is this interesting? Well, because I think it's critically important for us to link these infections because it tells us a little bit something about how individuals move around, have sex with each other, and where the hotbeds are, where the epicenters are that these infections continue to incur. Nonetheless, back to the partner study. Amazingly, there were no documented cases within the HIV couple, of HIV in the couple during condomless sex when the HIV positive individual is virally suppressed. The Partners PrEP demonstration project also provided further evidence for us and the treatment as prevention. For couples initiating ART in this study at enrollment, PrEP was offered through 6 months and then stopped. And for couples in which the infected partner delayed or declined ART, PrEP was continued until 8 months after initiation. In this particular study, there was high retention and high risk. There was high use of PrEP and ART. PrEP was initiated by 97%, and 82 had evidence that they were adherent to the medication. And ART was initiated by 91% of the individuals, and over 90% had viral suppression. What we saw in this particular study, and you're going to excuse me for a second because my old eyes don't always work so well, so I'm going to put my glasses on right now, is that the mathematical model showed that there was a 95% reduction in infections. It was estimated, based on the characteristics of the sample, that 83 infections should have occurred. However, there were only 4 infections that were actually observed, and that's quite remarkable. Opposites attract. Another source of evidence was a cohort study of gay men in serodiscordant couples in the countries of Australia, Bangkok, Thailand, and in Brazil. Approximately 350 couples were enrolled, and there were 591 couple years of follow-up. So they followed these couples over time. Couples reported almost 17,000 acts of anal intercourse without a condom. And what do we find here? We find very clearly from these data that HIV-positive men on ART with undetectable viral loads do not transmit HIV to their partners. And if you can see, if you look on the left-hand side of the chart, the first set of numerals, you will see a column called linked transmissions, and you will see that there are 0 linked transmissions. There's also evidence for the strength of treatment as prevention from the Danish cohort study that showed decreasing incidence and increasing coverage were highly correlated. What we see in this graph is the temporal change after the introduction of ART in 1996 in Denmark. And what you see here is as treatment and access to treatment and adherence to treatment goes up, HIV infection goes down. One of my favorite graphs is this one that shows on the bottom, on the x-axis, the proportion of individuals in a particular population who are on ART, and on the y-axis, HIV incidence. And what we see in the red dots, you see clusters of countries throughout the world. And what we see rather clearly here is this negative relationship. As ART uptake goes up, HIV incidence goes down. So this ecological study is another source of evidence for our work. So in summary, we have numerous studies from HPTN 052, Partner and Opposites Attract, that show us zero transmissions between HIV positive individuals with undetectable viral load and HIV negative partners. We see this in trials, we see this in observational studies, we see it all over the world. And I think the all over the world piece is really important because we know that culture and context matters. And so that if we can show that this particular approach seems to transgress culture and context, then we have a powerful tool on our hands. So, there's the evidence. That's the basis for U equals U. Undetectable equals untransmittable. So our friends in Switzerland in 2008 said this: an HIV positive individual not suffering from any other STD and adhering to antiviral therapy with a completely suppressed viremia does not transmit HIV sexually, i.e., he, she, let's add they also, cannot pass on the virus through sexual contact. The Swiss said this in 2008. The Prevention Action Campaign, led by Bruce Rickman, said this in July 2016. People living with HIV on ART with an undetectable viral load in their blood have a negligible risk of sexual transmission of HIV. Depending on the drugs employed, it may take as long as 6 months for the viral load to become undetectable. Continued and reliable HIV suppression requires selection of appropriate agents and excellent adherence to treatment. HIV viral suppression should be monitored to assure both personal and public health benefits. And the CDC, and then on September 27, 2017, the CDC adopted the U equals U statement, indicating in green here, when ART levels in viral suppression defined as less than 200 copies per milliliter or undetectable viral load, it prevents sexual transmission, bottom of the paragraph. This means that people who take ART daily as prescribed and achieve and maintain an undetectable viral load have effectively no risk of sexually transmitting the virus to an HIV-negative partner. The Lancet adopted the U equals U statement. UNAIDS adopted the U equals U statement. And as I said, the origins of this campaign were by a group of activists, part of the Prevention Action Campaign, that really wanted to chip away at the stigma associated with HIV, but also wanted to bring into modern times our understanding of how HIV transmission occurs in this era of viral suppression and in this era of treatment. As somebody who's been doing HIV work for a really long time, I will tell you that one of our main challenges is that despite the fact that we have all these advances and it is 2018, many people in our country still act like it's 1985. And that stigma associated with HIV continues to perpetuate this virus in our country as much as the virus itself does. So right now, there are close to 700 organizations around the world. Pardon the Mercator projection, it's not really accurate. Africa's much bigger and Europe's much smaller. And 90 countries that have endorsed U equals U. So, what are the public health and clinical implications of U equals U? Well, we know that for U equals U to be true, there must be viral suppression, right? An individual has to have low levels of virus in their blood. What we also know is that to get there, an individual has to be on treatment for approximately 6 months. It's not as if an individual goes on treatment today and has no viral load tomorrow. But we have very clear evidence that an HIV-positive individual who has a viral load, a high viral load, or any viral load, will get to the point where it's undetectable within a 6-month period of time. But this is highly dependent on adherence. Adherence means taking your HIV treatments all the time. And we know that for HIV treatments to be highly effective, an individual has to be adherent at least 95% of the time. So as much as treatment as prevention is a biomedical condition and a biomedical reality, we cannot separate it from behavioral realities. right? A person has to take a pill. And what I say to my students more often than not is that we can't treat HIV positive people as they are just as organisms that are simply have virus circulating in their bodies. They are individuals who have lives, who have families, who have spouses, who have partners, who have children, and adherence may not be the most important thing that they have to deal with in their lives. And so, fortunately, we have treatments that are less demanding than they were 20 years ago. Still, we find ourselves in challenging times here in the United States where of every 100 people who are living with HIV, some 40 are virally suppressed. It's better in New York and New Jersey, but New York and New Jersey do not typify the rest of the country. There are many benefits to U equals U besides the biomedical benefits, including the psychosocial benefits, which improves the lives of people living with HIV, dismantling HIV stigma, and really encouraging individuals with HIV to start and stay on treatment. See, treatment as prevention, and U equals U tells us treatment is not just good for you, it's good for your partner, it's good for your community, it's good for your population, it's good for our country, it's good for our world. One of the challenges we have, of course, with U equals U is making sure that we message correctly. We must encourage individuals who are living with HIV to stay on their medication, to stay in care, and to stay undetectable. I come back again to the issue I raised just a moment ago. For individuals who are challenged with many other things in their lives, psychosocial burdens and other conditions such as poverty and discrimination, who don't have access to transportation, who have children and don't have childcare, these are challenges that individuals will face every day of their lives, which will interfere with their adherence. Missing a few doses may lead to viral loads, but one shouldn't worry. As long as one is mostly stable and adherent 95% of the time, treatments will work. We have a responsibility in public health and as clinicians to think about our patients in a broader frame and to provide them the supports that take full advantage of these treatments that can better their lives and that can better the public health. Treatment as prevention must be considered as part of the toolbox that we have in treating HIV. That includes testing, condoms, PrEP, and PEP. One of the most challenging topics we're addressing right now is HIV criminalization. In the United States, majority of the states have laws that criminalize the transmission of HIV. However, HIV criminalization laws have not caught up with advances in treatment as prevention. What do we know? We know that if somebody's undetectable, they cannot transmit HIV. We also know that if people know that they're HIV positive and have sex with an individual, they can be criminalized. And so as a result, we must take care of these outdated laws to bring us into the 21st century. Thank you for that. I was going to sing for you for a moment, but I think it's probably best if I don't. Let me get back to the HIV criminalization thing because it's really important to me. Let me re-stress this. There are laws throughout the country that criminalize somebody who is HIV positive if they potentially infect somebody who's HIV negative. Now, what's the problem with that? The problem with that is if somebody is HIV positive and doesn't know, they cannot be criminalized. We want people to know their status. We want them to be on treatment. We must undo those laws. And right now, I'm very proud to say that I'm working with the Hyacinth Foundation and with Garden State Equality in New Jersey to undo these laws in our state. And I think we all collectively have to fight against these laws in our country. Laws have not caught up to where we are. Knowing one's status, unfortunately, with these laws makes one susceptible. So the laws we have are misaligned with target, test, and treat, and with U equals U. We know very clearly that condoms should still be used to prevent the transmission of other sexually transmitted infections, including gonorrhea, syphilis, chlamydia, HPV. Condoms are not essential if those are not issues for the person. A person who is HIV positive, who has undetectable viral load, cannot transmit virus to their partners. But condoms should be considered to prevent STIs in pregnancy, to account for the possibility that an HIV positive person may have challenges with adherence, to add another layer of protection, and to enhance a sense of responsibility. Biomedical prevention, treatment as prevention, PrEP and PEP, does not mean throw away the condoms. It means add all these tools to the other tools we have to continue to fight HIV in our country. There are public health challenges to E equals U. We know that access to effective treatment and state-of-the-art care is not equal throughout our country. There is acceptance, there is a lack of acceptance and trust, especially in marginalized communities, especially in communities of color, around issues of treatment. There are competing priorities that individuals face in affected populations. There is the ongoing stigmatization of a detectable viral load. And there's, in our country, as we all know, paternalistic attitudes about sexuality. There are also mythologies that we have to deal with to challenge U equals U. One mythology is that there is potentially, even though somebody's HIV undetectable in their blood, there is detectable virus in a person's genital fluids so they can transmit HIV. That's not really true. People have blips sometimes in their viral load, so they can transmit the virus. Blips are slight increases in HIV in the body. That's not true. That cannot transmit to HIV that way. And someone with an undetectable viral load with an STI can transmit HIV. Again, that's not true. The person can transmit the STI, but if the person is undetectable with regards to HIV, they cannot transmit HIV. So the clinical considerations for us are stay on treatment, stay undetectable, and stop transmissions. Viral blips do happen, but are not clinically significant. STIs have not been shown to increase risk for HIV transmission. And there may be HIV RNA and DNA in the genital fluids, but this does not create infection from the net positive person to the negative person. What you see in front of you is a graphic that was created by the New York City Department of Health and Mental Hygiene that was fashioned by my colleague Dimitri Daskalakis. And one of the things that he said recently at a meeting that I was at, which I love, which continues to destigmatize HIV in our country, is the following. When a person goes into care and they're found to be HIV positive, they go on medications. If a person goes into care and is determined to be HIV negative but at risk of HIV, they go on medications. In other words, let's stop separating the positive from the negative. Let's stop differentiating this way. Let's treat all people the same. The same medications that will improve the lives of positive people will improve the lives of negative people. Needless to say, U equals U has had a huge impact on people living with HIV. These are a couple of quotes from individuals living with HIV who the Prevention Action Campaign has spoken to. This is Cheryl from Victoria in the Seychelles, and who said, "I'm excited for the U equals U. Can't wait for people all around the world to be educated on this and to end stigma. For I am ready to break free and live without fear of discrimination. I thank all behind U equals U. Learning about U equals U has given me so much to look forward to." And this is Logan from Michigan who said, "I read an article today that a friend shared written by you. Big undetectable mistake. I just want to say thank you, thank you, thank you. I have been undetectable for 5 years as of June. I have had 2 HIV doctors, and the 4% risk of transmission is what I've always been told to communicate. Oddly, I also never felt this could be true, but didn't have evidence to confirm my feelings. And after my glasses, pardon me. And after all, I'm no doctor. The fear I've seen in men's eyes over the 4%, watching a blissful new encounter turning into one into fear. Your words confirm something I felt inside all along. Your words let me love myself a little more today. Your words told me that the 4% to F itself off and then freed me today. Thank you." I think those 2 quotes really demonstrate for me the power that U equals U has in destigmatizing HIV and in not making HIV positive people feel like they are somehow dirty or lepers that we have, in the way that we've done for the last 37 years. It empowers HIV positive people to feel powerful and strong and loved. And I think this is a critical component in continuing to fight HIV in our country. So I'm going to end today by sort of giving you a framework for thinking about U equals U and treatment as prevention for dealing with the whole person. Anybody who knows me will have heard me say that I believe that HIV in our country is as much a viral phenomenon as it is a social phenomenon, a psychological phenomenon, and a behavioral phenomenon. And so what I'm going to talk about today is addressing all aspects of the human using a biopsychosocial framework for embedding treatment as prevention and U equals U in our efforts to curtail AIDS. What you see in front of you right now are the goals of public health and HIV prevention and care. We want to prevent new infections, ultimately. We want to identify those who are infected, link them to care, retain them in care, treat, and suppress viral load. A biomedical approach to HIV prevention supports the efficacy of biomedical preventions, including TASPs, and this is true even when we have less than optimal results. One has asked, what is the problem with behavioral interventions? There has been some questionable effectiveness in terms of behavioral interventions, but behavioral interventions were all we had prior to biomedical advances. The focus and the reason that they've had questionable effectiveness is because they focused on reducing risk for infection. And for me, what the real problem was with many of these models for HIV prevention that we developed over the course of the previous 20 or 30 years was that they treated human beings as rational operators. As if somebody with high self-efficacy who was out at a bar having a good time would say, you know what, I'm going to wear a condom because I have self-efficacy. We know that human beings are not rational operators. They make decisions based on emotions. And so those models kind of fell apart for me. Nonetheless, is the solution to get rid of behavioral interventions simply because we have biomedical ones? Obviously, as a public health psychologist, I will tell you that my answer is no. What I think we need to do is marry biomedical preventions with behavioral interventions. And I had the great privilege in 2012 in serving on the Committee on Psychology and AIDS of the American Psychological Association, where we formulated a resolution that called for the combining of biomedical interventions and behavioral interventions to fight HIV in our country. That ultimately, the integration of these things, of these approaches, would be the most effective. I will take you back to a comment I made maybe 20 or 30 minutes ago, which is, yes, treatment as prevention is about medications, but treatment as prevention is also about a person and a behavior. And so unless we monitor the person and the behavior, the medications are not going to solve the problem themselves. They're not going to magically pop into somebody's mouth every morning in order to suppress the HIV. So what do biomedical studies teach us? They teach us that despite their critical importance and their effectiveness, they involve a human component. They only work when there's uptake and adherence, and we cannot separate the person from the intervention. So I've told you about two things, behavioral and biomedical. And then there's the third thing, the social. Science clearly shows that social conditions and structural inequalities challenge us in our fight against HIV, and that those who are poorer, who have less access to health care, who are discriminated against, who experience racism, homophobia, who are victimized, who experience gender bias, or any of these biases due to their intersectional identities, are more susceptible to HIV. Multiple minority stressors place people at risk for HIV. People do not live in vacuums. They live in societies and in contexts and in environments where all these social conditions shape their lives. So what am I saying to you? I'm saying to you that the solution to the HIV problem in our country is an approach that marries the biomedical, the behavioral or psychological with the social. In and of themselves, each are powerful. In combination, they're more powerful. Combination HIV prevention is one that integrates all of these three things. And I have said all along, since the implementation of HAART since 1996, we use three classes of medication to fight HIV, right? The different medications attack the virus at different points in the replication. why would we not use a three-pronged approach to HIV prevention? We should be attacking things socially, we should be attacking things behaviorally, we should be attacking things biomedically. So PrEP, PEP, and TASP to deter infection, behavioral support to support uptake, adherence, and maintenance, to develop an understanding of PrEP and to reinforce condom use and safer sex strategies, and social policy to combat social inequities and to decrease vulnerability to HIV infections. My colleagues Rich Walitsky and Greg Millet and I, a few years ago, wrote an article for the American Psychologist where we considered this idea a little more fully. And I think this is a really helpful paradigm. This is not an all-encompassing paradigm, but it's certainly a starting point for thinking about HIV and moving our work forward. HIV in 2018 cannot be thought separately from other health conditions. Where we see HIV, we see substance use. Where we see substance use, we see mental health burdens. Where we see mental health burdens, we see violence and STIs. And you can add myriad other health conditions to that bubble. These are multiple epidemics or multiple health disparities that synergize with each other, that catalyze each other, that make each other worse. And that in order to attack these multiple overlapping health problems, these multiple epidemics that in this theory, in this conceptual model is referred to as a syndemic, we must address the biological drivers, the behavioral drivers, and the psychosocial and structural barriers. And I also had the privilege, after Governor Cuomo called for an end of AIDS, to serve on the task force. And for those of you who are interested, this amazing, amazing blueprint that we put forward actually addresses these very ideas. That certainly the medicines matter, but so do the social conditions and so do the behaviors. I've had a great fun talking to you today. I love sharing this information with you. If you'd like to learn more about the work that we do at CHIPS or about my own work, there's my Gram and my Twitter and my website and my Bitmoji. Maybe it should be a little grayer the hair, I don't know. And I appreciate you being here today for this webinar. Thank you very much.
So the first question that we have today is, if we know all of this information that you've presented, why do we still have HIV in our country, especially the United States?
Yeah, so that's a great question. We have the tools. We should have zero infections in our country. We should have everybody treated and living healthy lives. But this comes back to one of the last ideas that I presented in the webinar today, which is people live in contexts and in communities and in populations and in countries in which social conditions create disparities, in which social conditions create inequities, in which social conditions create challenges. So, while HIV may have been the primary presenting problem for me as a young man in the 1980s when I came of age in New York City, it may not be the primary presenting problem for others. And in fact, I just recently published a paper in Health Psychology looking at a new generation of gay men and their worries. And while HIV is one of their worries, it's not the totality of their worries. And so we must nest HIV within the current time and within the social conditions and fight the inequities that perpetuate the epidemic. I would say the same thing to you if you asked me about cigarette smoking, which is we have to create social conditions that make people not want to smoke.
Great. Another question is about taking PrEP. So this person says, what are the effective messages or methods for convincing healthy, negative people from or towards living a life of taking medications?
So my message would be to the individual who asks this question, you probably take care of other parts of your being. You probably exercise regularly. You probably eat in a healthy way. I would embed taking PrEP as one of these behaviors. You are taking another step to protect your life and to protect your health. And so think of it just as another strategy you're doing to live a healthy lifestyle. And if you know that even if you are at slight risk for HIV, why not empower yourself and have the control over your body to be able to prevent you from getting HIV. Ultimately, take a pill every day for a while to prevent yourself from getting HIV. If you acquire HIV, you're going to have to take pills for the rest of your life.
Great point. While we're waiting for more audience members to ask questions, I'm going to ask a question. You talk a lot about treatment as prevention, which raises to me this idea that it could prevent researchers from working towards a cure, something that completely gets rid of HIV. So what are your thoughts on that? Will the treatment as prevention campaigns prevent a cure?
I don't think so. Like cynics would argue that the pharmaceutical companies just want to continue to sell their treatments, and so they will not be as motivated to seek cures. But I think scientists who always advance the work are very much dedicated in identifying vaccines and cures. We're very much, on the path. I don't know if we will have a vaccine or cure in my lifetime. I would like that. I've always said I would be happy not to do HIV work, as I get older. But I think I know the scientific community is focused on continuing to find a cure. This is a temporary patch. This is the best we have right now. In 1985, it was just condoms and some behavioral approaches. In 2015, we have TAS, PrEP, and PEP. I hope in 10 or 20 years, we have a cure and a vaccine.
Thank you. Still waiting for the audience to, if they have any other questions, to please type it into the chat box and it'll be read aloud. Otherwise, this is going to be another question for me and potentially our last question. So, Dr. Halkitis, in terms of researching the effectiveness of combination HIV prevention, where we're using biological factors, psychological factors, and social factors, what are the next steps in terms of researching those types of programs or looking at how effective those implementation of those programs are?
So I can tell you what I'm interested in the grant that I'm writing.
Please do.
I think that we have spent a lot of time developing interventions that are place-based. And what we know nowadays is that individuals are highly spatially mobile, and individuals use apps and extend their networks beyond their own neighborhoods and communities. So what I'm interested in doing is developing interventions that actually tap into this spatial mobility, recognizing that people don't just stay in the West Village or on 168th Street, but travel throughout the country and throughout the world. And how do we message and intervene with this technology we have in our hands, right, to provide messaging in real time to people no matter where they are? That's what I think the future is. Recognizing that, hey, you're in Barcelona and having a good time. Here's a message for you that addresses HIV to keep you focused on the health of your well-being. That's what I think the future is, the app world.
Okay, we have one more question.
All right.
From our audience. This person asks, are there any implications for the Affordable Care Act and U=U policy in the U.S.?
Yeah, I mean, I actually do think there are huge implications. I think, look, right now, PrEP and medications and treatments are covered. In the United States, Medicaid and Medicare covers PrEP, and healthcare companies cover PrEP. I think the minute you start denying people health insurance, and they cannot afford to take this treatment, cannot afford to get the medications, then of course it has implications. In a very similar way that young men in our cohort study would come to our research center and tell us consistently they can't afford condom and lubes, and they would use lubricants that were not sufficient in protecting them from HIV. So we have to make it is a responsibility for us to ensure that people continue to have access to these treatments and to treatments as prevention and to PrEP, and that is predicated on people having health insurance. So absolutely, there are implications for this if the Affordable Care Act continues to be chipped away at.
Thank you so much. So we want to extend a very warm thank you to Dean Halkitis for giving this presentation. We're very thankful that you were able to come in today.
Thank you.
We want to say to our audience members, if you liked our webinar, or if you didn't, please take our evaluation at tinyurl.com/August 2018 evaluation and tell us what you would like to see in our next trainings. Starting September 2018, we're going to have a new webinar series focus. We're moving away from health disparities, health equity, and social determinants of health in order to address strategic skills for the governmental public health workforce. So stay tuned for more of that information, and thank you for tuning in today.